to give his lecture about the management of small renal masses, watch or treat. Dr. Marzouk, he's a urological oncologist at Al Sabah Ahmed Urology Center in Kuwait. He had his medical degree in UK, followed by a residency in McGill University and fellowship in Uro Oncology in British Columbia.
Good afternoon, everyone. I hope everyone enjoyed their lunch. My name is Ahmed Al-Marzouk. I'm a local urologist. And first of all, I would like to thank the organizing committee and the Arab and the Kuwaiti associations for this kind invite. I was tasked to cover the topic of management of small renal masses, whether to watch or treat. And I'm hoping I'll be able to do this in 10 minutes. I have no disclosures, and this is a quick outline of what I'll be discussing. Really, the emphasis of the talk is not to debate which is better, but more to emphasize the dilemma that faces a urologist when making these decisions. We will discuss briefly the management options, and then the rest of the emphasis will be on how to choose the best management strategy. But before I do any of this, I'd like to define exactly what we're talking about. I will be covering the topic in the sense of covering small, solid, and cortical renal masses, those masses that enhance on cross-sectional imaging with contrast. I will not be covering masses that are incidentally found on ultrasound. We will not be covering cystic masses, AMLs, masses, small masses that are invading into the vena cava or into the perinephric fat. And speaking of small masses, we've had this pandemic of cross-sectional imaging, the widespread of it and the steep increase over the last 10 to 15 or perhaps 20 years, which has created a new issue for us, which is the incidentalomas in the kidney. We've had a steep rise in the incidence of these small tumors. However, when we look at a mortality, the mortality remained the same, which is quite disappointing because we've had a stage migration, but without yielding any favorable results in treating a pretty aggressive cancer, if we think about it. And the reason for this is because the vast majority of these masses are stage 1 disease, stage 1 RCC. And if we look at this graph here, we see that almost 70% are stage 1, and almost half of these masses are T1A. So half of the incidentally found masses are less than 4 centimeters, which is really what we'll be discussing today. One way of looking at it is this is earlier treatment. Earlier treatment usually means better cure rates, and that may be true, but this comes at a price. We look here, and this is a surgical series, and we find that for masses less than 2 centimeters, almost 40% of these masses are benign. So we're subjecting these patients to unnecessary surgery, we're over-treating them. We're subjecting them to general anesthesia, to potentially a complex surgery if it was a partial nephrectomy, the stress, the anxiety that comes with it, and not only them, the patient and their family as well. And we see this rate continues across the different sizes at up to 3 and up to 4 centimeters. It's close to 20, between 15 and 20%, and then it drops steeply afterwards to 10 and 5% in the larger masses. So this is just another slide to emphasize that within this benign population, there are some oncocytomas, and some of these oncocytomas carry a low malignant potential. But if we remove them out of this discussion and we focus solely on purely benign disease, we see that we're still overtreating a lot of patients within this population. This is another slide to show you that it's not just benign disease that we don't necessarily need to treat, but even some of the malignant lesions that we find are low grade, grade 1 and grade 2, which are rather indolent and are unlikely to cause harm. And we see with this slide that higher grade tends to happen with larger sizes. The larger the mass, the more likely for it to harbor high-grade disease. Continuing to cover our tumor biology discussion, we also look at the metastatic rate. The metastatic rate is pretty low for masses less than 2 centimeters, but it's not zero. The metastatic rate can reach 2% in masses less than 4 centimeters, which is something that needs to be borne in mind when we're counseling patients and we're trying to make a decision whether to treat or to watch this mass. I like this study because it pooled especially the earlier experiences in surveillance, and we looked at about 880 patients, and this over a period of 3 years, almost 3 years, and the mean size was 2.3 centimeters. So we can't really ignore it because of low grade or unlikelihood of metastasis, because it crossed the 2 centimeter line. What the authors found is about a quarter of these patients, they just don't change. There's no growth over a period of 3 years, and none of these cases metastasized, which is pretty reassuring. However, the 2% was consistent across all these studies, and time to metastasis was approximately 40 months. When they did a subgroup analysis in this paper, they found that the rate of growth was quite a strong determinant of whether these masses metastasized or not. And we see there's a significant difference between 0.8 and 0.3 centimeters a year. This is just a graph to illustrate what the authors found. And that if we look at the combined graph, it doesn't look like these masses grow a lot over time. However, we can see there that the larger the size, the more steep the growth curve is. And if we look on the right, we find that even some of the malignant masses don't grow necessarily that much, emphasizing again that some of the malignant masses are indeed indolent. This is a series from Toronto, also illustrating the same, very similar findings. The reason I put this picture up is I want to illustrate two things. If we look at the masses that remained stable over time, they tend to remain stable over time. And the masses that start growing with some pace at the beginning, these are the ones that tend to grow. So growth rate seems to be a recurring theme here. However, within that same series, we look here, some of these masses shrunk, and some of those masses that shrunk were malignant. On the other hand, we see some benign masses that grew on the other side of the spectrum. So we're not really answering any question by sort of ping-ponging between whether this is going to be a harmful disease or not a harmful disease. There remains a dilemma of deciding which patient to treat and which patient not to treat. Despite all the reassuring evidence, there are a handful of patients that will progress, that will harbor higher grade disease, and that may have aggressive disease that will metastasize. And the dilemma continues with the lack of biomarkers. We don't have any blood or urine tests to tell us whether these patients do indeed harbor malignancy or not. We don't have any radiological tests. In fact, radiology put us in this problem. Even in the best hands, we do not have anything in radiology to tell us whether this mass is malignant or benign. In nuclear medicine, some scans show some promise. A sestamibi scan can tell us with a good degree of confidence whether this is an oncocytoma or not, but that's where it stops. In the pipeline, there's things like carbonic anhydrase 9, which may be able to pick out clear cell RCC early on, but this is, I think, still years, will take years in development and validation. And finally, we don't really have any nomograms, no clinical nomograms to aid the surgeon in making any of these decisions. We mainly use life expectancy, or at least in my practice, this is what I use. So the management options, we know them all. They're endorsed by all the urological guidelines, NCCN, European, American, and Canadian. And we know they're more or less equivalent in terms of outcomes, oncological outcomes to be specific. I'll not be talking much about the biopsies because I believe this is the topic for the next speaker. However, if we look at treatment versus active surveillance, this is one of the largest series where they covered 10,000 patients. And there seems to be a benefit, a statistically significant benefit, that favors treatment versus no treatment. However, in a subgroup analysis within the same study, they looked at the population that's over 75, and this benefit disappeared. So age, growth rate, and age are factors that don't seem to be favoring treatment. This is another study that illustrated very similar findings. This was for a population over 70 that underwent partial nephrectomies. We look at the overall survival, there's a big difference. However, cancer-specific survival, there's no difference, which tells us really that these patients, their comorbidities are likely to get them before their cancer does. And this is what we call competing risks. This was illustrated again in a radical nephrectomy series, which showed that deaths from kidney cancer are more or less stable or stabilized over the years. But when we look at the patient's comorbidities and their frailty status with the Charlson score, the worse the score is, the earlier they pass away. So what about renal function? We're removing kidney. Surely there's a loss of GFR. Well, we know with ablation and partial nephrectomy, we don't really lose that much. In most cases, it tends to be stable, or it drops by 5 or 10%, depending on the size of the mass and how many nephrons or how much bulk of the kidney you've removed. But then again, we have evidence that tells us that even radical nephrectomy is not necessarily that terrible towards these. This is a randomized paper from Europe that compared partial and radical nephrectomies in bilaterally healthy kidneys, and there was no difference in end-stage renal disease in these patients over a long period of follow-up. So, how do we decide then? Well, we know that age is a factor, and not necessarily chronological age per se, but age and comorbidities. We've all come across 55-year-olds, heavy smokers, end-stage lung disease that we cannot really subject to surgery. And we've also come across 75-year-olds that go to the gym on a daily basis and are otherwise healthy.
Can we conclude, Dr. Ahmed?
Yes. Tumor size and characteristics, they dictate the management a lot, and growth rate, as has been illustrated. So this table, I'll put it up at the end just to show pros and cons of each approach. And to conclude, patient and tumor factors seem to be dictating all the decision-taking in this area. There's no room for any heroic interventions. There's no benefit for any heroic partial nephrectomy in a 70-year-old. They're just not going to get the benefit of that surgery. There's no one-size-fits-all strategy for these patients. We know that from the discussed evidence. And the treatment has to be tailored towards each patient and their needs, and the characteristics of their mass. Limitations on morbidities come with most of these treatment approaches, including active surveillance. So the key here is shared decision making with the patients. I'm just going to put up this table, and I'd like to thank you all for listening, and I'll be happy to answer any questions.
The next presentation, needle biopsy of renal mass. Always, sometimes, never. We invite Dr. Jonathan Noel. Dr. Jonathan Noel is consultant urologic surgeon practicing at Guy's Hospital in London.
Very well from the previous speaker. I'll put a timer on, but just give me a minute warning if you wouldn't mind. So the background, small renal masses, less than 4 centimeters. The question is, when we get a biopsy and it is benign oncocytoma, do we believe it? Or is it that angiomyolipoma that's not fat-rich? Obviously, there's malignant varieties as well. But oncocytomas can account for 80% of all small renal masses. We know this. So who to biopsy? In our opinion, and supported by guidelines, it's patients prior to commencing active surveillance, prior to ablative, patients with tumors on both kidneys, hereditary syndromes, prior history of cancer, and prior to any systemic therapy. Who do you never biopsy? Patients who are unfit, what will the biopsy change? Patients with cystic lesions and coagulopathy. Then there's those people in the middle. That's a question that hopefully at the end you'll have some light on, or maybe you'll leave with the same questions. In an ideal world, we could accurately distinguish between benign and malignant renal masses and limit that over-treatment of benign tumors that we saw on the previous slide, those small renal masses where the benign rate is quite high. So we don't want to undertreat malignant ones either. So how do we find the right balance? Imaging has caused a pandemic of incidentallomas, and has it helped us to define which ones are malignant or not? Unfortunately, it hasn't. Each one helps with the diagnosis, but then what do we do after? The argument for biopsy, from my point of view, is it's an accurate test which can confirm or help confirm a diagnosis. In centers that routinely do interventional radiology-guided biopsies of kidneys, it's safe with low risk, and it can prevent a significant morbidity of over-treating. And it gives patients some information, and most patients would like it, even if inconclusive. Renal biopsies can be accurate, can be low risk. This meta-analysis in 2016 of 5,000 patients supports this. Complication rates are there, and it has to be considered that it will make a partial nephrectomy quite difficult after a biopsy. Seeding risks with coaxial needles is pretty much a thing of the past, although nothing is ever zero. But negative biopsies can prevent overtreatment, supported by these two studies. Retrospectively, the first one looked at routine biopsies, of which 5% were benign, and the ones who didn't undergo a biopsy and underwent surgery had 16% benign rate. Which one would you favor as a patient? Renal tumors, biopsies, retrospective study. Renal biopsy was avoided, active treatment in 27% of patients in this 122 patient series. So what are the consequences of a partial nephrectomy? This is our consent form from the British Association of Urological Surgeons. You can see partial nephrectomy can be complex. Even if it's a small, low-lying fruit, there's always the risk of major complications, bleeding, loss of the kidney, urine leak. We quote 5% typically. But a better informed patient means a happier patient. They are part of the decision-making process. Positive biopsies can provide information on grade and histology, and you can see the differences in terms of the diameter. They're predictors of growth rate, and they can influence the decision we make for the patient. Now, to argue against biopsy, as some of you in the audience may be thinking in your head, it's not as accurate as you may think. Why are we talking about biopsies? We may miss significant cancer if it comes back as benign, and it's not always readily available in every setting. And how safe is it? Well, how safe is a benign biopsy to watch? You can see that the positive predictive value of an oncocytoma is 67%. So that means that renal cancer can exist in 1 of your 4 patients with a benign biopsy. That is something that would argue against biopsy. But will it change your management? If you're considering surgery for this young patient that will reap the benefit, you could argue, no, it won't change my management. And if it's positive, your management plan will be still to proceed. Patients would be exposed to another investigation with the risks of bleeding, with the risks, although low, of tumor seeding. But if it's negative, will your patient accept the risk that it's a false negative? And would they be happy to be surveyed? And we have good criteria based on growth rate that we've seen in a previous presentation, that if it does go above 0.8 centimeters in a year, that patient will be at risk. And they need to know that. So this was a snapshot audit from the British Association of Urological Surgeons 10 years ago. And you can see small volume, but nonetheless, 91% of respondents do not biopsy before they perform surgery. So there's lots of variability in the centers. I'd be interested to know during the question and answer session what the local and regional experience is here. But has our practice evolved over time? Routine biopsy, where not commonly performed or readily available, may not be as accurate. So volume matters. What you do in your center matters. How confident your interventional radiologist is matters. So where's the middle ground? That's the road that we're going to take now. Risk stratification based on size. We know from lots of studies retrospectively that there's a relationship between size and malignancy. Obviously, less than 1 centimeter, 38% risk that it's going to be benign versus the big 7 centimeters where it's going to be likely malignant. I don't think anyone would biopsy a 7 centimeter or more tumor. But should size of the lesion affect the decision to offer a biopsy? Then we heard from the previous speaker about new scans that are coming. This scan obviously is going to be looked at in a trial of which we are a center that's recruiting to see if technetium sestamibi can actually help define oncocytomas versus RCC. And those are the reviews, systematic review, which showed sensitivity of 92%. So I think careful counseling is important. Most cases, the choice to biopsy or not biopsy will be patient-led, but also center and what they can offer. And the attitudes and expectations can vary significantly. But in 2023, a biopsy of small renal masses from our local practice should be offered, and it allows our patients to make an informed decision. And at Guy's Hospital, we tend not to do any challenging partial nephrectomies on globally challenging patients. That's always been our mantra. And we avoid high-risk partial nephrectomies, particularly for benign disease. We come together every week in multidisciplinary fashion, which is routine, to argue the pros and cons for every case, but we routinely offer a biopsy. But I think the trial of the technetium scan will be very interesting in years to come. So to conclude, renal biopsy is sensitive and specific. It is probably underutilized, and that's been proven in many reviews, even in Britain. It can be shown to reduce overtreatment, and that's what we're trying to do. But patients should be offered it, counsel, risk, benefit, like everything. And I think a risk-stratified approach is important. And this is the final slide, just to show you how we biopsy different organs and really drawing your attention to the pre-treatment biopsy rate. The last column, last row, 7% for kidneys. All the others are 100%. Thanks for your time.
Thank you very much, Dr. Jonathan. We'll move to the next speaker. I'll invite Dr. Nibras Al-Hamadani for presenting the renal masses. Dr. Nibras Al-Hamadani is a clinical professor in Medical City in Baghdad, and he is president of Iraqi Urology Association.
Okay, good afternoon. So we'll go to reality. We will present some cases for our panelists. See, regarding the topic you just heard. I'm Dr. Bulbul, I'm from Lebanon, and thanking the organization for having us. So our panelists today will be Dr. Nibras Hamadani from Baghdad, Iraq, and Dr. Amin Reyes from Bahrain. So we'll start. Let me see. Okay, so gentlemen, this is up to, you just heard two beautiful presentations on management of small renal masses. One of the few challenges really we have in renal cell carcinoma, and as was mentioned by our first speaker, radiology helps, but not to the degree. And it's one of those things in urology, as mentioned at the last slide, that we treat upon the result of biopsies, except in renal cell. We accept it somehow. So let's see if the mood has changed. So this is a 72-year-old diabetic man, hypertensive, diagnosed with 2.5 centimeter solid right renal mass. His creatinine is normal. 72, diabetic, hypertensive. He has this mass, as you see it, in the right kidney. Well, we'll start. Nibras in Baghdad, would you biopsy this mass? The current practice, not the ideal scenarios.
We usually in Iraq, we do not use biopsy for standard, because if it is enhancing mass, and I can see it from here, it is exophytic, we will go to the partial nephrectomy, whether laparoscopic or open. So we do not do biopsy in routine.
So biopsy in Iraq is not routine for small renal masses.
No.
How about in Bahrain, Ayman?
You know, I can speak for myself. So given the age and the comorbidities, my practice is biopsy with a coaxial needle, because I agree with Dr. Nibras, it's enhancing. It's more likely malignant, but given the size and the availability of thermal ablation in my center, given his comorbidities and the location, I can offer him percutaneous microwave therapy. So that's why I would biopsy this, and then give him the option of either thermal ablation or laparoscopic partial nephrectomy.
Okay, I think Jonathan listed the reasons to why to biopsy or not. I might add one, if you're really looking for a reason not to operate.
Professor Mohammed, only in Iraq
Yes.
we have no thermal ablation or focal therapy for the renal masses. This technique is not available till now. So that we are going to the surgery for, and we are not encouraging biopsy. That's just a comment.
Okay. So Nibras, you will do a partial on the 72-year-old diabetic hypertensive. Ayman will do ablative therapy. What really make you decide which one way to go or the other?
For me,
Yeah.
yes, because for him it is he's diabetic and upper level of renal function. I think that the other kidney is functioning. It's normal. So he can benefit from the partial nephrectomy, and he can live his life. There is little bit complications post-operatively. Not too much for us. And beside that, we have no ablation therapy or focal therapy for renal masses available in Iraq. I have to send him outside, so it is not economically cost-effective for him, for the patient.
So availability of technology will also influence your decision to go one way or another.
For sure.
Okay. Any comment, Ayman?
Yeah, the availability of technology and an excellent interventional radiologist.
Absolutely. Absolutely. Well, okay, we'll go to another case. So biopsy or not, therapy. So this is a 34-year-old man with this 3.8 centimeter left renal mass. The question here, as you see it, and this is, we can actually show you some video on this. You can just see that. How close to the hilum it is or not, or what do you think of this? So, the question here is, would you biopsy this one, Ayman?
This one, looks like RCC. I'm more likely going to operate.
Looks like RCC, smells like RCC, must be RCC, right?
Yeah, unless the patient pushes me, I would not biopsy this. I would book him for a laparoscopic partial nephrectomy.
And if the pathology comes out being non-malignant, it's good. He can rest assured. Would you do another studies? Like, for example, we heard a lot about the system-EB to differentiate from onco or something else. Right. Has this been our routine practice? I mean, we know what maybe we can't do, but in your practice at home, would you do system-EB for this one?
It's not yet available. I'm not confident in the report I'm going to get, so that's why I haven't started yet doing the system-EB scans. But this one doesn't look like oncocytoma. It looks more RCC, so that's why I'd just go with the lab partial here.
So, Nebras, what would you do to this guy? You'd offer him a partial or a radical?
I agree with Dr. Ayman. I will do partial nephrectomy for him.
Partial nephrectomy?
Yes.
Okay, we'll go to another case. We have some time still. So this is a 42-year-old healthy man with a 5-centimeter right renal mass. And I'll show you this mass. See how it's coming up now? See that mass coming? So it's a big one, encroaching, a bit central. Okay. Would you do a partial or radical? What do you think, Ayman, for this one? And as we heard from our first speaker, the Van Poppel study comparing partial and radical, really the results were almost in favor of radical, but there were some issues with the study, difficult to recruit, and this. What will be your impression for this one?
I mean, you always would love to do a partial nephrectomy, but this one seems like it's difficult with the nephrometry score.
So what do you tell your patient? I'm going to attempt partial. If not, I'll do a rectal for you.
So I start laparoscopic as probably most of my generation now. We start lap. I'll mobilize the kidney, but this one I'll convert to a subcostal incision. Give it a go. Tell them that the complication rate is going to be high for a partial nephrectomy, but the advantage is preservation of nephrons. I'm more likely going to end up with a radical, but I always like to give it a go, give it a chance for a partial nephrectomy.
Nebras, what would you do?
Well, we will counsel the patient. We'll give him both chances, and I will tell him I will start the surgery, and then you have to give me the approval to do whatever I will see, which is better for him. So that either I will do partial if it is feasible for me, but I think for this case it will be radical. I faced one case like this before. We did lap for partial, but we told them that maybe. And when we see it, it looks higher stage than it was seen in the CT scan. So we converted to radical nephrectomy after that. And we spoke with the patient, and he was agreed. He was signed on before preoperatively.
Okay, so this is a decision you still have to make. One of the controversies, should I go a partial on this one? Some guys are heroic and will go for it, but you have to take the patient as a whole and talk to him. Maybe a last case. This is a 44-year-old man with hematuria and flank pain. This is a CT scan. It's a big mass. He has also a left vein thrombus. Would you give this guy adjuvant therapy, or you would not? Probably you'd proceed with surgery for the sake of time. After he was operated on, the pathology came out to be PT3A, invading focal vascular invasion, no sarcomotoid features. Is there a role for adjuvant therapy in 2023 now for such a patient? Ayman, what do you think?
Would be better off with a medical oncologist, but yes, I'd refer him to a medical oncologist and, you know.
Yeah, I think you may be aware of the key 564 that shows that basically randomized Pembro. Pembro is probably the only one that came out. The Prosper did not come out with other immune checkpoint inhibitors, but Pembro now is recommended for these type of patients versus placebo. I think we are on time. Good. Any questions from the group? Yes.
As the extract matured.
You mean to downstage it?
No.
Locally?
In the adjuvant setting after the surgery.
Okay.
As the extract trial matured, we came to know that as soon as the TKI, the sunitinib, is stopped after 1 year, actually the overall survival is not attained. Extract was the only trial which showed an initial advantage in the disease-free survival for the patients who were subjected to sunitinib after surgery. But the long-term data suggests that there is no overall survival advantage. Therefore, the initial category of recommendation in NCCN, which was 2, has been shifted to 3. With maturation of Keynote 564, we know that the effect of pembrolizumab is long-lasting. That means even when you stop pembrolizumab after 1 year, you get an absolute overall survival. So today it is indeed the recommendation has now gone to category 2, and which maturation of 564, it is going to go to category 1, because this ASCO, they had that presentation. So it is the way that we start looking at adjuvant therapy in locally advanced disease. That is what I was trying to say. So second thing was the Telix is now FDA approved. That means zirconium labeled gerentuzumab is available now as an FDA approved tool to identify clear cell carcinoma by doing the zirconium labeled gerentuzumab PET scan. So that is going to come to our side of the globe soon. So I want to make this.
Thank you very much. Thank you. Any further points?
Thank you, Dr. Bulbul.
Thank you.
And I would like to thank Dr. Mbras and Dr. Ayman for this nice discussion. We'll move to the next presentation by Dr. Bulbul, updates on the management of non-seminoma germ cell tumors, RPLND and chemotherapy.
Okay, we'll continue, just also for the sake of time. My job this afternoon to talk to you about, finished from renal, we'll go to testes, and an overview really of basically non-seminomatous germ cell tumor. I don't need to tell this body that really testis tumor has very distinguishing features. It occurs in young men, and the metastatic pattern of spread is really very consistent. It's chemosensitive, it's surgery sensitive, and chemo failures can be salvaged by surgery, and surgery failures can be salvaged by chemo. It's one of the most structured solid tumor that we have, and we have consistent results, really. What are the risk factors? You all about this. Intratesticular germ cell neoplasia is one. Microlithiasis, we used to think so, probably not anymore. Contralateral testis cancer, cryptorchidism, as you all know. These are the risk factors. I don't know why they're coming this way again. gonadal dysgenesis, marijuana, family history, all these come up to you, and trauma. We rarely get a testicular cancer patient who hasn't had trauma sometimes. He will always tell you this. But anyway, okay, what are the pathology of germ cell tumor? We all know about the seminoma, and we are interested today about the non-seminoma, the embryonal, the teratomas, the yolk sac, and the choriocarcinomas. Markers. One of the few really nice solid tumors that we have is testes has really consistent serum testicular markers. And they have helped us a lot in initial diagnosis, in assessment of risk status, monitoring response, and surveillance after treatment, also for relapse. And the alpha-feto, beta-HCG, and also LDH will help you do that. And they are incorporated actually also in the staging of testes tumor. I'm not going to tell you about stage 1, basically confined to the testes. You have stage 2, 1 and A and S. S is for persistent markers. Stage 2 is metastases to the lymph nodes in the abdomen. Depending on the size, you can classify them. Stage 3, outside the abdomen. So how do we treat clinical stage 1 non-seminoma? There are a few facts about it, that if the patient is clinical stage 1, it's very well known that occult metastases are present in 30%, documented. Most of the time, 90 of those metastases, 90% are in the retroperitoneum. Certain factors in the orchiectomy specimen will tell you one way or another. Vascular invasion is one, and the presence of embryonal carcinoma is another thing that will maybe swing your decision to proceed with treatment. What are the treatment modalities? Really, orchiectomy can cure up to 80 or 85% of those patients, up to 90 for low risk. Surveillance, RP-LND, or chemo. There are certain features like lymphovascular invasion will put you at a higher risk strategy, and we said also the embryonal carcinoma. Also, RP-LND is favored with those secondary somatic malignancies that you see in the testes. So let's take active surveillance. Clinical stage 1 non-seminal germ cell tumor. We observe those patients. It's because of the knowledge. This has been over, like when I was at Memorial, over maybe now 40 years ago, this is what the strategy. This has been entrenched in our specialty, active surveillance. And patients are serially evaluated by markers and imaging. You know 30% of those are going to relapse, but they are salvaged by chemotherapy after that. It's unlike seminoma, those who get chemo might need to have surgery at some point. RP-LND is the second option for clinical stage 1 non-seminal germ cell tumor. What are the benefits? You really stage it. You like to know what's going on. But surgical lymphatics are curative as well if there is occult metastases. And this will probably decrease the need for chemotherapy in the future. What are the disadvantages? Well, you're operating on 70% that you don't need it really. So we know that from facts if you want to operate up front on clinical stage 1. And patients with occult tumor outside the retroperitoneum, if they have it, they will need chemotherapy anyway. The nerve sparing, not going to spend too much time on it. We use it because the disease occurs in young men. And these people fertility is important for them, and they need to keep their ejaculation. And this is I don't need to show you this, you already know it. These are the terminology. And the AUA guidelines has all this. You have, if there is disease in the retroperitoneum, you have to do a full bilateral. If there's no disease, you can start doing the modified bilateral, modified right, or modified left, depending on the case. But the modified resection should never compromise the quality of the node dissection. Whether you should leave on the left side, leave the paracavals or so, it's a bit controversial. Chemotherapy is the third option you have for clinical stage 1. You give a BEP, either 1 or 2 cycles. Advantages, cure rates are very high, and good options for somebody who really cannot come for active surveillance. In people who live very far away, it may be a one-stop shop, and maybe that'll be it. So you gotta have to weigh these with the patient. Disadvantages, again, you're treating almost 70% of those who don't need it. And there are the long-term risks of chemotherapy. So which one we should use, really? We should use active surveillance, we should RP-LND or whatever. I think it's a discussion with the patient. I think you will have to make that informed decision with the patient. But for the compliant patient who lives beside you, active surveillance is probably the way to go. For the sake of time, these are the AUA guidelines. For clinical stage 2 disease, well, which is evidence in disease in the retroperitoneum, small volume disease can be treated with either chemo or RP-LND. High volume disease, you start with chemo and see around some of those will gonna end up having RP-LND as well. So depending the size of the disease, the size of those nodes will decide which one way to go, also discussing it with the patient, all the scenarios you have. For patients less than 5 centimeter, RP-LND can be curative in more than 85%, depending on the volume of metastases. If primary chemotherapy is given, around a third of those after will require RP-LND, but you will have saved 2/3 the RP-LND, 2/3 of the patients. So it's basically a trade-off between the two, and has to be discussed with the patients. Some centers in the world favor RP-LND, others favor chemotherapy to start with, and because at the end, these patients are gonna live. They're not dying of their disease. The cure rate is around 98%. So whichever way you go, it is a win-win situation. These are the AUA guidelines as well for all the stages of stage 2, for the sake of time. For stage 3, we always start with chemotherapy, and we risk stratify our patients like anything else we like to do in oncology. Risk stratification is important, good, intermediate, and high risk. And according to those, you will give the cycles, the number, and the type of chemotherapy that is needed. So, for finally, testicular cancer, the high cure rate attained in this disease are due to the advances really in medical and surgical therapy. One of the probably solid tumors that we can talk about cure, which is not for many years now. So this is really very encouraging. Oncologists and urologists have to work together in an MDT atmosphere to attain the best and to give the best advice for the patient. It really testis tumor serves as a model for our MDT meetings. Thank you very much.